All right. We will go ahead and get started. Thanks, y'all, for being here. We are very excited today to welcome Dr. James Bailey as our speaker for Grand Rounds. Dr. Bailey, are you able to share your slides?
Sure.
Okay. While he is doing that, Dr. Bailey is the Tennessee State Grantee PI for Evidence Now, Building State Capacity. He also serves as the Robert S. Pearce Endowed Chair in Internal Medicine, Professor of Medicine and Preventative Medicine, Director for the Center for Health Systems Improvement, and Executive Director for the Tennessee Population Health Consortium at the University of Tennessee Health Science Center. In addition to being PI for the AHRQ-funded Tennessee Heart Health Network, which seeks to support and strengthen primary care practices across Tennessee in their efforts to improve cardiovascular health, he serves as PI for the aligned CDC-funded Innovative Cardiovascular Disease Program, which seeks to promote and disseminate evidence-based approaches to address social determinants of health, underlying adverse cardiovascular outcomes, and disparities in collaboration with community health centers serving Tennessee census tracts with highest prevalence of hypertension. He also serves as PI for the Neighborhood Health Hub program funded by grants and contracts from United Healthcare, Shelby County Government, and the Kemmons Wilson Family Foundation. Dr. Bailey continues to practice general internal medicine as a primary care physician for adults with complex chronic illness and teaches doctors in training. His ongoing research focuses on patient-centered approaches to improve healthcare delivery, quality of care, and health outcomes for people in medically underserved areas with multiple chronic conditions. Thank you for being here today, Dr. Bailey.
You're welcome. Thank you for hosting me. Well, I'm really looking forward to this journey together into the community and to think together about what we can do to build healthier communities in the cities and regions where we live. Um, let's see if I can advance my slides here. There we go. I have a few disclosures. Our team gets grant support from the National Institute for Minority Health and Health Disparities, Agency for Health Care Research and Quality, which, as you know, many of you know, is under siege and being subsumed into the Administration for a Healthier America. CDC, United Healthcare Services, Tennessee Department of Health, and Shelby County Government. I serve as a board member in the Coalition for Better Health and president for a consulting company called The Healthy City. But all our clinical recommendations here are evidence-based and free of bias. And I'll just, I think you've probably seen the objectives. We're going to really try and delve into the evidence here about the effectiveness of motivational interviewing-based health coaching for promoting weight loss, hypertension control, and diabetes control and remission. And we'll really go into the proven benefits of place-based neighborhood level care. And we'll describe how health coaches and other community health workers can improve medical practice performance, help you do better what you know how to do best as physicians. And we'll explore some of the most promising approaches evolving around the country for reducing unnecessary spending on high-cost sickness care by extending essential preventive care into the community. So let's get started. And I want to start with the challenge. And you have very similar challenges in Atlanta as we have in Memphis. In our lower income neighborhoods in particular, the focus on end-stage rescue care is striking and disheartening. One of our Congregational Health Network pastors said of his neighborhood in South Memphis, now there are more dialysis centers in my neighborhood than primary care clinics. How backward is that, right? It's very distressing for those of us that care about their patients that people find it easier to get dialysis than they do primary care. And this, particularly in the South, impacts medically underserved African American people, among whom over 50% of diabetes and hypertension is uncontrolled. And that poor chronic condition management leads to ridiculously high rates of ER use, hospitalization, complications, and death after things have gone bad, right? We wait until things go bad and then we spend tremendous amount of money trying to bring people back from the brink. You've heard about this South Memphis community where we do a lot of our work. And we looked at what this pastor had said, and we actually drove around a little bit and discovered that he was exactly right. We could count 6 dialysis centers, and very conveniently located in our South Memphis community, and not nearly as many primary care clinics. And we saw that, as the people in that community do, as unjust and not the kind of just health care that we want for all Americans. Numerous studies demonstrate that people in the United States lack access to essential preventive services. You guys know, I'm sure, about diabetes education and the benefits of good diabetes education, and also diabetes prevention program services, which in numerous studies have been proven to improve outcomes for diabetes and for prediabetes in turn, right? And yet, this map shows that across the country, despite Medicare having covering diabetes education services and diabetes prevention program services for about 4 years, um, um, and even longer than that for diabetes self-management education, there are very few places around the country where you can get these services. They don't come close to matching the need. And there are a variety of reasons for that we'll talk about as we go on. But it's actually very hard for people in low-income communities where rates of diabetes, obesity, and cardiovascular disease are the greatest to get these really essential preventive healthcare services. Now, where did America go wrong in its healthcare system? And 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 as I look back, one of the foundations for our rescue care approach was the Flexner Report, which was encouraged by Fred Gates, a Baptist preacher, who encouraged the Rockefeller family to invest heavily in the new scientific medicine that was being developed, which was a very good thing, based on laboratory science and addressing the infectious disease um, uh, epidemics of America. Fred Gates encouraged the Rockefellers and encouraged Simon Flexner to focus on really putting our support behind hospital-based medicine, around laboratory-based medicine, which works a little better for infectious disease than it does for cardiovascular disease. But as a result of the Flexner Report in the 1930s, all of the medical schools ended up closing because they lost federal support, that admitted women, that admitted Blacks, and there was a more intensive focus on um, laboratory-based medicine and the care that people could get for infectious disease in the hospital. Some of that work happened at the Rockefeller Institute, where Florence Sabin was. And the result of all that was the development of these huge hospitals, these temples to healing, one way across town where people could go when they became desperately sick. And this is actually Cornell, just to show you a few examples of these beautiful, beautiful hospitals where we as doctors feel so secure because we have all the physiologic parameters, and we can, often feel more control of the care process than we do in the chaotic environment of the clinic. But the data shows that neighborhood availability of care close to home strongly predicts what's called realized access, real access to the most essential preventive and primary care services. And yet, our investment in these neighborhood services is in many areas of the country really insufficient. But this is the solution. We know that availability of care close to home really works, right? And making it easy, convenient, simple for people to get the care they need most. Because of that literature, we at the University of Tennessee developed the Neighborhood Health Hub model to demonstrate a new place-based model for extending primary care into neighborhoods of greatest need. And there are a few things that are different about this model. We didn't realize how unique it was when we introduced it. First, our health hubs are entirely staffed or nearly entirely staffed by trained and certified health coaches from the communities we serve. We do our very best to try and recruit our health coaches from the communities served. Most of those health coaches have some experience in healthcare, often as an MA, or other health-related fields like nutrition. And they set up their mini clinic in a population center in a medically underserved neighborhood. We try and locate close to a safety net primary care provider, so we can do bidirectional referrals that are convenient and easy. And what our coaches do is they identify social, mental health, and medical needs, and they seek to address those needs and seek to help patients become the most active force in their own healthcare. And we'll talk a little bit more about the motivational interviewing approach, but it's very much an evidence-based, empowering approach for helping people make lifestyle changes that are very hard to make and require a lot of support. So we'll come back to this, but let me press ahead. So all of you know about social determinants of health, and I think it's important to remember that they are not a new idea, right? We both have Atlanta and Memphis, strong traditions and around the work of Martin Luther King, who through his Poor People's Campaign really put the emphasis on social determinants way before it became so popular, knowing that better jobs, better education, and better homes were the things that ultimately contributed most to health. And you probably remember his quote: of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. So as we think about the factors that really influence health outcomes the most, it's really a no-brainer that we need to be focusing on both health behaviors and social and economic factors, right? That those are the bedrock of human health. And so our coaches in many ways start there. Clinical care is important, particularly primary care, and contributes about 20% to physical health, but not nearly as much as healthy behaviors and social and economic factors. So I think that's important for us to remember, even in the clinic, that smoking cessation counseling, referral for behavioral intervention for obesity, may be some of the most important things we do there. And it's important to think about those social factors in the context of the leading causes of death in the United States and how they've changed. Heart disease is right at the top, of course, right? But as we look at the actual causes of death, the behavioral factors that contribute most to death, back in 2000, tobacco was clearly the leader, right, in terms of actual causes of death. But poor diet and physical activity, what we call obesogenic behaviors, were a close second to tobacco. And now that's really flipped to, as recently as 2010, dietary and activity patterns became the leading preventable cause of death or actual cause of death. While tobacco is still important, it's not as important as those obesogenic behaviors. And so as we think about what our health coaches and our health system as a whole needs to be most focused on, we have to think about this plague of plenty, where we've gone, in the 1980s, where less than 10% of people in every state were obese, to now where, particularly in the South, many states over 30%, some approaching 40% or more, are obese. And in the neighborhoods where we work, 50% of people struggle with obesity. And yet, obesity so seldom ends up on our problem list when it needs to be at the top, right? So we can look at this and the problem we have in the South in heat maps. And this heat map shows, of course, where we are in Memphis. We are right in the center of the obesity belt in the country, with extraordinarily high rates of obesity in our region and in the Deep South. And following, of course, with obesity, we see a very similar map for diabetes, heart disease, heart attacks and strokes, diagnosed kidney disease. All of these patterns are very similar, and they follow that root cause of obesity. And I like to ask people, what do you think are the main drivers of obesity? And I know you all know that it's a whole mirage of factors in terms of those social determinants of health that undergird unhealthy eating and inactivity, low levels of physical activity. But I think if I had one factor to blame, put at greatest blame, I'd say it's addictive, high glycemic processed food. That it's the germ, it's the vector driving obesity. And I'm going to just quickly go through a little of the evidence on that. You I think know what processed food is, basically anything that comes in a package, right? And ultra processed foods like soft drinks, chips, you can't eat just one, and processed meats, for example. Those non-nutritious, high glycemic processed foods drive weight gain, right? More than anything else. And this drive to consume these high profit but low nutrition foods that's been supported by our agricultural policy for the last 50 years really began in the 80s. And it was promoted by interests like Lay's potato chips. And I like this just as an example. I'll show you this brief clip.
Lay's potato chips. Bet you can't eat just one. Nobody can do that. A potato you can slice this thin makes a chip so light, so crisp, you can eat a million of them, but nobody can eat just one. Delicious.
Well, you guys probably know that chips are the #1 weight gain food, right? And they are highly addictive. The people who've studied food addiction tell us that on a scale of 1 to 10 in terms of level of addiction potential, food ranks about a 6, where morphine is only about an 8. And these high calorie, high carb, salt and fat loaded foods are truly addictive and hard to break away from. If you've got chocolate chip cookies in the house, it doesn't matter who you are, you're probably going to find them. But the interesting thing is that if people are given a really high quality, delicious Mediterranean style diet, they enjoy it just as much and they have much better health outcomes. So, so healthy eating shouldn't be seen as a sacrifice. And I think this deprivation mentality has been one reason that we've had trouble encouraging and supporting weight gain. One of the studies that really brought that home to me was the study from Cell Metabolism, where they did a crossover trial where they randomized 20 adult patients to receive an ultra processed diet for 14 days and then an unprocessed diet, a natural food diet for 14 days each. And they were randomized as to which they got first. And the diets had equal amounts of calories, sugar, fat, fiber, and micronutrients. They were nutrient identical, but the people were allowed to get seconds. That's what the ad libitum part means, is you could go back for seconds. And the bottom line is that when people have access, when they're fed ultra processed foods, their sugar goes up, it plummets down, they're hungry again, and they've got to have more. And so people on the ultra processed diet ate on average 500 calories a day more on the ultra processed diet. And that turned into marked differences in weight gain in a very short period. In just 2 weeks, there was roughly a 1 kilogram weight gain in the ultra processed diet, a 1 kilogram. So that's almost 2.5 pounds weight loss in the natural food, unprocessed diet that was well prepared. That's huge. Here in 2 weeks, people lost, there was a 4 pound weight difference, almost 5 pound weight difference in only 2 weeks between eating this non-nutritious, ultra processed food versus natural food. And interestingly, food satisfaction in the two groups was identical. There was no difference in food satisfaction. Healthy food sticks with people longer, right? So some of this research has encouraged us to think, even before Ozempic and the other GLP-1 and SGLT2 agents came on the scenes, that people might be able to reverse diabetes using diet. And some of the early data on this came from the Look Ahead study, which I think Emory was involved with. We were involved here at UT Health Science Center in Memphis. In Look Ahead, they saw that a small number of people, maybe 10% of those with early diabetes, could actually achieve remission with intensive counseling and weight loss. And I want to briefly review one of the most exciting studies that has shown this potential through, in essence, counseling, and that's the DIRECT study, the Diabetes Remission Clinical Trial. And it was done in Scotland and England and used total diet replacement using a liquid diet. And this is intensive weight loss, which we have to be careful with. But they put people on an 830 kilocalorie diet, markedly reduced calorie diet, totally replaced their normal diet with these nutritious shakes, and they, on initiation of the diet, because it was so intensive, they stopped all their diabetes medicines and all their antihypertensive medications, and of course, monitored blood sugar and blood pressure. And they only included people who had only had diabetes for about 6 years, because we know if people have had long-standing diabetes, it's really hard to reverse diabetes, right? And what they saw was with health coaches, nurse health coaches based in clinics, that they were able to achieve 14.5 kilogram weight loss on average and maintain it for the people who stayed with the study, which is unbelievable, 30-pound weight loss. And they achieved a quarter of the people achieved more than 15 kilograms of weight loss, and nearly half, 46%, had complete remission of their diabetes. In other words, had consistent A1Cs below the diabetes range off of all anti-diabetes medications. So really incredible. So from this study, we see 50% remission of diabetes if you get serious about counseling early. And they found that the more weight people lost, that the more likelihood of remission that they had. 73% were in remission with 10 kilograms of weight loss. And they found that with ongoing counseling, and they've had follow-up for almost 4 years now, people were able to maintain weight loss and maintain diabetes remission on the whole through real change in their eating habits. They transition them off of the liquid diet onto a maintenance diet, a natural diet. And this is a good point to just remind you of the study, it's been about 15 years now ago, where they did a direct randomized controlled trial comparing alternative diets for weight loss. And what they found was, even though with a low carbohydrate diet, the very high protein, the keto diet, that you do achieve greater initial weight loss with that keto diet, but there's much more weight regain. And we know weight regain, weight fluctuation up and down is very unhealthy. And what we've learned is that people can't maintain that keto diet. It works great when you're in ketosis, but if you keep eating bacon when you get out of ketosis, it is not good for your health. Whereas the Mediterranean diet is truly delicious and more it's the healthy diet that people can maintain and enjoy for a lifetime. Everyone really agrees now that for long-term weight loss and maintenance, Mediterranean diet and changing diet for life is the way to go. So this sort of points out what our coaches need to do, right? And how they need to make food our medicine, right? That food is the most important medicine we can offer people. Well, the U.S. Preventive Services Task Force came around a few years ago and recognized the strong evolving evidence for behavioral weight loss interventions. And now behavioral weight loss interventions are recommended to be offered to everyone with obesity. And I wish I could see your hands. Actually, you can use your electronic hand and raise your hand if you have a place from your clinic to refer people for intensive multi-component behavioral interventions to address obesity. Yeah, and if somebody wants to count hands, I can't see them all on the screen right now, but I don't know if it's like this in Atlanta, but until we really got this Health Hub program growing, we had no place to refer people and to follow this recommendation from the U.S. Preventive Services Task Force. And by the way, it's a grade B recommendation, which makes it as good as strong evidence for multi-component behavioral interventions as there is for mammography. And of those multi-component interventions, one of the most evidence-based that the USPSTF held up was health coaching, motivational interviewing, based health coaching. So let's talk a little bit about that. Motivational interviewing is incredibly well evidence-based, and effective weight loss trials in particular have used highly diverse interventionists. And what we've learned is you can train a lot of different types of healthcare workers to do motivational interviewing effectively. And we have a world-class training program that's mostly online in motivational interviewing that some of you might be interested in if you want to seek certification. It's a new way of counseling, and it takes some getting used to. But we've got now extensive evidence that motivational interviewing is more effective than education. Hear that. Motivational interviewing, encouraging support is much more effective than education for weight loss. Usually patients know what they need to do. It's just really hard to do it, right? And this is some of a meta-analysis, a summary of the results of a meta-analysis showing that the number of randomized trials that have shown that motivational interviewing is more effective than education. And furthermore, motivational interviewing has been shown to be highly effective for a whole bunch of behavioral conditions like addiction, smoking cessation, etc., diabetes control, hypertension control. So it is a very evidence-based technique that lay health workers can learn and be effective in delivering. Now I'm going to talk just a little bit about our research and into the effectiveness of health coaches in primary care, supported by the Patient-Centered Outcomes Research Institute. That program was called the Management of Diabetes in Everyday Life program, and it was all about finding patient-centered approaches for helping people in their daily lives get to control or even get to remission. And we developed the interventions that we tested through extensive input from patients and community stakeholders. And I won't go into that in any detail, but just to say we did over 25 focus groups and surveys of patient groups over the last 5 to 7 years. We do a lot to find out what our customers want, right? What they see as effective, what they think will work in their community. And that leads to effective interventions, right? We listen to build trust, and we do a lot of patient panels at our heart health summits, where patients tell providers their perspectives about what are the types of care they need most, what are the health resources they need in their community. And this slide summarizes the evidence from our model study. We enrolled patients with uncontrolled diabetes in 3 behavioral interventions: health coaching, personalized text messages, and educational materials alone. And one of the first things we learned is that most of the time when people with diabetes go to the clinic, they don't get consumer-friendly educational materials. They don't get visual, actionable, interesting educational materials. And part of what we found was that even educational materials are effective. This was a randomized controlled trial. It was pragmatic because it was carried out in actual primary care practices serving medically underserved neighborhoods. We enrolled almost 700 African American adults in 19 practices, all who had uncontrolled diabetes. And we randomized these folks to these 3 different intervention arms. And what we saw first off, our main outcomes were related to healthy eating behaviors and exercise behaviors. And we found that both healthy eating behaviors and exercise behaviors improved by about a day a week in all three groups. Healthy eating behaviors improved a little more in the text messaging group versus the educational materials group. The health coaching group and the text messaging group were almost identical in their effectiveness. But of interest, it was only the health coaching group that reduced BMI significantly. So part of what we concluded is that all three of these interventions ought to be more routinely delivered in primary care. Personalized text messages from the doctor's office, encouraging messages, educational materials that are patient-centered, and health coaching. And I won't go through this other than to say our focus group showed that people really liked getting health coaching. They liked that direct interaction and relationship with their health coach. Yet the text messaging group found that the text messages helped keep them motivated and accountable. And our study isn't the only study showing that health coaches are effective. This is a study in Louisiana that demonstrated significant weight loss in people with intensive health coaching, that they were able to achieve over 5% weight loss from baseline with health coaching alone. In our work, we've targeted our most medically underserved neighborhoods with the highest prevalence of hypertension. We have 30 census tracts in the Memphis area that have hypertension prevalence in adults of 53% or higher. And we use our data network we get feeds from clinics and hospital systems across the community. And we're really able to zero in on the neighborhoods at highest risk of uncontrolled hypertension. This is showing people with uncontrolled hypertension above that 130/80 mark. So let me return as we close here to this neighborhood health hub model and what we found it can do. We have slowly been expanding our number of these health hubs. And we've partnered with our major health systems to provide this person-centered, trusted approach. And it's all about engagement, right? It's hard to engage patients as co-partners and really empower them around helping them get to goal and improve, understand what's needed to be at goal and for their own care. But patients want better health for themselves and their family. And one thing we found is they're really excited to see that there's a way that they can be major contributors to their own health journey. This is what one of our health hubs looks like. And we have exercise classes as well as diabetes prevention program services, diabetes self-management education services. Everybody who comes through the door gets screened right when they come in, and we screen people quickly, though we make sure we get a good blood pressure measurement. We screen them quickly for obesity, hypertension, and diabetes, as well as social needs. We offer them individual or group health coaching, and then we take some time to connect them to needed care, whether it's primary care. Sometimes we have to send people to the emergency room, behavioral health, social services, etc. I'll not talk right now about Heal Diabetes, but we do have a diabetes remission program. And we've now actually had over 18,000 visits at our health hub locations, and we've served over 3,000 individuals. And almost 50 to 60% of people who come through our doors have obesity, about 50% have uncontrolled hypertension, and about 35% have high blood sugar. We get referrals from healthcare providers, primary care providers who want their patients to get diabetes education, for example, or obesity. We encourage providers to refer all of their patients with obesity, and they're thankful to have a source to refer people to. We do a lot of community health fairs at all, and we get a lot of walk-ins that help us recruit people into the program. On average, our clients with obesity lose 4 pounds, and that includes a lot of people who come back maybe one time. But once people have come back a second time, the average number of visits to the Health Hub is about 6 to 8 a year for people, that 30% that we really get our hooks into. We see almost 15 millimeter reductions in systolic blood pressure and similar reductions in random blood glucose and average blood sugar for the people with diabetes, where we're trying to get point of care A1Cs as well. And we're rapidly increasing our volume. I won't go through this, but people tell us they come to the health hubs for psychosocial support. One patient said, "You feel like they really care when you go there." Empowerment. A patient said, "I changed my eating habits. Everything changed. I'm trying to equip myself to manage my own health, being in control. True enough, I have diabetes, but diabetes don't have me." And patients recognize that they get tangible benefits from coming there. This is just one example. This woman who has allowed us to share her name, Penny Ward, she had a heritage of strokes and heart attacks in her family and lives cut short. But she said to us, "I can say my blood pressure is lower now than it's ever been in my entire life. When I last checked, it was 123/78. I don't ever remember having blood pressure that good. My A1C is below 5.5%. And when I first started, my A1C was 10%. And this is my first time being under 200 pounds in 43 years." That's the kind of life change that happens in our health hubs, and it's been so fulfilling to be part of that. I'll skip through this. We've talked about our model, and y'all have heard it's really all about engagement and relationship that keeps people coming back. And now in this last year, we expanded to 3 locations, and we've expanded to 4. And by the end of 2026, we expect to have 5 locations across the Memphis area. And we've gotten major support from the mayor's office and our county commission. But increasingly, we're trying to integrate this into our larger health systems, so that they routinely refer all patients with obesity and put prevention first and emphasize prevention first, as it should be. So referrals have been one of our major goals, and we're moving into insurance billing so that we can move on a path to sustainability. We are currently beginning to bill Medicare, Medicaid, and even many private insurance companies for services. So the path to sustainability is difficult, but we are working to get there. And part of it is by making this part of the mainstream, and to recognize that everyone deserves a health coach and can with help, chart their path to a healthier future. And I think that's all my slides. So thank you for your time, and any questions?
Dr. Bailey, thank you for that. I think many of us appreciated not just your discussion, but being able to learn about some of the incredible work you and your team is doing. It looks like we already have some questions. This is a wonderful program. What strategies can be used to address food deserts and improve access to healthy food? An excellent question.
Yeah. Many of you may have even more knowledge than me about that area, but it's very difficult. We do try in our cooking classes to partner. We partner with the food bank, and we often offer food, free food, as a tangible benefit, and give people experience in preparing it. So we've worked a lot with the grocery stores as well to help get them to support some of our food programs. So I'd say we're working some on the demand side. There are policy changes, around the country where we'd love to move is to have a food pharmacy, right? And one of our partners has a small grocery store where they're able to sell groceries, and the grocer that works with them gives them the same discounted price. But, similar to primary care, to make fresh, healthful food accessible and profitable, you need small shops again, right? You don't need just big grocers. You need small shops close to home that people can access, and there has to be a demand for their products, and they have to be affordable. So some of that really gets into policy, right? And our advocacy for agricultural policy that supports locally grown and healthful food through our WIC program and through our agricultural subsidies. So it's a big, multifaceted problem, but I think we, through our advocacy efforts, can help increase food access.
Our next, go
Yeah.
ahead.
No, go ahead.
Our next question, how much funding? Oh gosh, so many questions all at once. Can you share some examples of the text messages sent to patients as part of the trial?
Yeah, we use our text messages are very encouraging, motivational. We tested a lot of them, and we'd be happy to share our text message library with you if you have interest. But we found that patients in our community, and we think this is true of other similar communities, prefer really encouraging motivational messages that may include statements or references to faith. But they don't, people did not respond well to finger wagging measurement. I mean, finger wagging messages like, you need to do this, right? Or really purely educational messages. But messages like, particularly if you can tie it to things like blood pressure improvement and say, way to go, keep up the good work, getting your blood pressure to goal at less than 130/80.
How much funding was required to start this initiative, and when do you think this will be sustainable long term?
Oh, that's a $1 million question, no pun intended. But we started small with one health hub supported through philanthropic funding. We got some follow-up funding and support from United Healthcare, actually, through some of their health equity and community reinvestment work, and have slowly built the support to open these other hubs primarily through philanthropy and philanthropic foundations, but also the county government has become a major partner. And of course, in our city, county government does health and is over the health department. And they actually have invested in it as a way to help their employees, in part, get preventive services close to home, close to the workplace. So it's been a real blended approach. We've negotiated with our state Medicaid providers for uniform payment standards for health coaches. And that's a model that you could follow in Atlanta. Payment rates are low for a lot of those preventive services. So we're really trying to build efficiency in making sure we code for and bill for every billable service to at least maximize that. But I think we're at least a good 5 years from full sustainability by saying that without philanthropic support. And I think it takes some shared savings models, value-based payment for outcome, to help supplement the fee-for-service payments that people providing these sort of services currently receive.
Dr. Bussy Jones asks, can you talk a bit more about the connection of the coaches with the health center? Are they employees with access to the electronic medical record, or are they external partners? How do they communicate and or document in the medical record?
Wow, we think that's part of the path to sustainability, right? And we are a separate healthcare organization. Our health hubs are operated by UT Health Science Center and our medical group, which is called University Clinical Health. But our major clinical partner is a federally qualified health center, which was excited for us to offer these services next door. So we've tried to co-locate where we can. We use the Epic electronic medical record, and that's been integrating that has been a challenging journey. But as a result of using Epic, some of our partners, even that are on Epic, are able to see our health coach notes. And so now we're getting some investment from United Healthcare to help us develop electronic referrals with our major health system partners, where we can actually more easily do bidirectional referrals. So right now we do paper referrals, primarily where, it's a self-referral by the patient. So, we're really trying to make our be fully embedded in the healthcare system, but have it be a collaborative venture, right? Now, if your health system is big enough, you could certainly add this service. And I think there's a path to sustainability there.
One more question. Have you had a chance to discuss healthy food options with food industry reps ever?
That's interesting. I guess, follow-up question, if you'll pitch in on this. By food industry reps, do you mean like Coca-Cola?
Dr.
I mean,
Kabate, are you
I'm
able
going to
to?
assume you mean Coca-Cola and Frito-Lay. I think we need to have those conversations, right? And I've struggled personally. One of the organizations I work with, we had an event co-sponsored by Coca-Cola. I felt very conflicted having Coca-Cola signs at a health event, right? On the other hand, some of these companies have some healthy product lines. Of course, I think bottled water is a travesty, to some extent because of the plastic generated. But there are some potential for healthy products and some healthier products out there that we may be able to get behind, right, with those companies. I think at the same time, this is a social justice issue, and that we need to partner with the people of our most afflicted communities by the harms of unhealthful food to stand up and advocate together for healthy food for all humans, right? And there can be a business case for healthful food, but we need the incentives to be right and healthy incentives supported by a healthy government. But I encourage people to have those conversations with the food industry and partner wherever we can with food providers that do offer healthful options, even McDonald's, for example.
With the high rates of obesity in youth, is there integration of the program within the pediatrics department?
Yes, we at one of our locations actually have a physician there 60% of the time who is a med peds doctor, and we've been working to develop our pediatric programs. So we currently offer health coaching to youth and to families. And some of our cooking classes, for example, with parental participation, we have youth and kids involved. So we definitely think that peds is a key part of this, and referrals from pediatrics and from dentistry, right? Every child and every adult with bad teeth has an eating problem, right? So we really can champion healthy eating in all sectors of the health system with a little effort.
Any other questions from our audience?
Well, thank you for your time. And my email is jeb@uthsc.edu. So if I can share any material, anything of help to you and your work there, let me know.
Thank you, Dr. Bailey. Thank you all for being here, and we hope you have a great rest of your week. Bye, y'all.